Welcome to our video on Leishmaniasis and Trypanosoma Cruzi. Let's get started. Here's our overview of the topics that we're going to cover, and we're going to start with Leishmaniasis. And as we discuss this particular topic, we'll go over the general features, clinical features, and the diagnosis and treatment of Leishmaniasis. Now, Leishmaniasis is caused by the protozoan Leishmania, and it's transmitted by the bite of a female sandfly. And there are three clinical forms of Leishmaniasis. There's cutaneous, mucocutaneous, and visceral Leishmaniasis. So let's start with the cutaneous form. The cutaneous form presents as an ulcer at the site of the sandfly bite. And that's pretty intuitive. You think the sandfly bites, so what does Leishmaniasis, the cutaneous form, look like? Well, it'll be an ulcer at that area of the sandfly bite. And that ulcer may remain as a mild, localized infection, but it can disseminate, producing widespread non-ulcerating nodules. But again, the ulcer is at the site of the sandfly bite. And if the cutaneous form is disseminated, then you get all these nodules elsewhere on the body, but they're non-ulcerating. Now here's an image showing a typical ulcerative lesion of cutaneous Leishmaniasis. Now, mucocutaneous Leishmaniasis presents as destructive and disfiguring ulceration, and that involves the nasal mucosa or the oropharynx. In addition, pharyngeal involvement may actually cause respiratory compromise. So you can see why this would be dangerous. Once you get this infection in the mucous membranes, then you worry about the throat, respiratory compromise. And this brings us to the last type, visceral Leishmaniasis. This is also known as Kala-Azar or black fever, and it's a systemic illness that's caused by Leishmania. And this can be asymptomatic, or it can present with fevers, splenomegaly, hepatomegaly, and pancytopenia. And this may be complicated by superimposed infections. And that makes sense because if you're bringing down the level of immune cells in pancytopenia, for example, leukopenia, then it makes sense that the patient is now more susceptible to other infections. Again, this systemic one is called visceral Leishmaniasis. So how do you diagnose this? Well, to visualize the parasite, you need a slit skin smear, and that can be taken from the cutaneous or the mucocutaneous forms of the infection. So basically, you just see an infected site and you take that sample. But in the case of visceral Leishmaniasis, you're going to need a splenic smear. And what you're going to do in either case, whether you take a splenic smear or a slit skin smear, is you're going to use a Guillemot stain to visualize a mastogotes. And other helpful tests are serology or even a PCR for rapid diagnosis. So once you've diagnosed it, how do you treat it? Well, Leishmaniasis is treated using sodium stibogluconate or meglumine antimyonate, which is the mainstay of therapy for most regions. And in case there's a resistance to those drugs, then you can use amphotericin B. Next, let's discuss Trypanosoma Cruzi infection. So just like in the last topic, we're going to discuss general features, clinical features, diagnosis, and then treatment. Now, Trypanosoma Cruzi is a flagellated protozoan which causes American trypamoniasis or Chagas disease, and it's typically seen in South and Central America. And this is transmitted by the feces of the redivid bug, also called the triatomine bug. Now, the bugs bite and then they defecate in the same area. And in that way, the contaminated feces are introduced into the host body through those mucosal abrasions. And when that infection is introduced into the body, there may be dusky red swelling at the site of the inoculation, and that's actually pretty uncommon. However, when it does present, specifically on the eyelid, it's known as Romanes sign, and I'll show you what that looks like in a minute. What you'll see is a unilateral lid swelling, and that's characteristic for acute trypanosoma infection. So here's an image showing Romanes sign. See, it's on one side, and it's lid swelling, and that's characteristic of an acute infection, sometimes called Chagas disease. Now, an acute state of illness can occur in a minority of patients, and in those patients, they'll have fevers, lymphadenopathy, rash, and hepatosplenomegaly. And in a minority of patients, a latent infection with trypanosoma can occur and cause a delayed complication, and what you're worried about there is dilated cardiomyopathy and or destruction of the Auerbach's plexus of the GI tract. And that's really bad because it can lead to achalasia or megacolon. These are radiographic images of patients with a megacolon caused by Chagas disease. So in the first image, the one on the left, you can see dilation of the rectum and the sigmoid colon. And in the second, the one on the right, you can see extensive dilation of the entire colon, hence the term megacolon. Well, how do you diagnose this? Well, for diagnosis, the protozoa can be visualized using a blood smear, so pretty basic. And PCR and serology can be other helpful diagnostic tests. So here's what a thin blood smear of the patient will look like. So in the center, you can see a flagellated trypomastogote. And once you've diagnosed it, you then treat it. And you treat it with nifurtimox and benznidazole. So let's just wrap up with a quick small question. What are some of the long-term complications of Trypanosoma Cruzi infection? So the answer is dilated cardiomyopathy, or the result of Auerbach's plexus being damaged in the GI tract. What does that cause? Achalasia and megacolon. And that concludes this section.